Hello, everyone. My name is Ving Nguyen, and I'm a PGY1 pharmacy resident at Phoebe Putney Memorial Hospital. Please feel free to pause the video anytime to better evaluate slide contents. This year, I have been evaluating the association between the exposure of different doses of unfractionated heparin for venous thromboembolism prophylaxis in hospitalized obese patients. I have nothing to disclose in regards to the information that I will be presenting. After this presentation, the audience will be able to utilize the information presented to apply to clinical practice by assessing the association between body weight dosing of unfractionated heparin with various outcomes. Venous thromboembolisms occur due to stasis of blood or abnormal clotting cascade activation. All forms are dangerous and can be fatal with long-lasting negative effects. Different analyses have shown that first occurrences are higher in obese patients, such as the statistics shown on the screen. So what do we know now? Current guidelines recommend standard dosing of pharmacologic prophylaxis to prevent VTEs in hospitalized patients, with no recommendation for the use of body weight dosing in obese patients, even though treatment dosing of these pharmacologic agents are weight-based. This is due to the lack of prospective data in this patient population. Over the past decade, more studies have been evaluating the use of body weight dosing. One of the largest retrospective cohort studies in this topic evaluated the use of body weight pharmacologic prophylaxis with heparin or enoxaparin in hospitalized obese patients. This study concluded that body weight dosing approximately half the odds of symptomatic VTEs with no increased risk of bleeding in patients with a BMI of 40 or greater. Even though this study found a large difference, other studies either found similar trends or no differences at all. Based on the previously mentioned study, my research team and I wanted to evaluate the use of different dosing methods in our health system. The primary objective was to evaluate the association between standard dosing, which was defined as 5,000 units every 8 or 12 hours, and body weight dosing, defined as 7,500 units every 8 hours, of unfractionated heparin with the occurrence of hospital-acquired VTE in obese patients. To assess the primary objective, the endpoint that we evaluated was the occurrence of VTEs through diagnostic tools. Our first secondary outcome was to determine the association between different dosing methods with major and/or minor bleeds. We utilized labs and hospital stay information to determine the different types of bleeding. Our last secondary outcome was to assess the utilization of a pharmacist-driven protocol in our health system. This protocol allows pharmacists to utilize body weight dosing if a patient meets both criteria. However, some pharmacists utilize their clinical judgment and adjust with only one criterion. We attempted to evaluate if dose adjusting with only one criterion affected the occurrence of VTEs. This case-controlled retrospective study evaluated two cohorts. The case cohort consisted of patients who were diagnosed with a VTE, while the patients in the control cohort were not. All patients had to receive at least one dose of unfractionated heparin within 48 hours of their admission, and both cohorts were matched utilizing their age and length of stay for a ratio of 1:4. We utilized this study design to see if the exposure to different dosing methods of unfractionated heparin in the past affected the outcomes. Here are the inclusion and exclusion criteria. I would like to point out that we excluded those admitted for knee, hip, and cardiovascular surgery due to specific guidelines for these patients. After the approval of the IRB, 499 patients' charts were reviewed, with 444 patients being excluded. First, all patients were evaluated for their weight, BMI, and the time of their first dose of unfractionated heparin from admission. Afterwards, they were evaluated for other exclusion criteria. We included 11 patients in the case cohort and 44 patients in the control cohort. The average age was 71 years, and the average length of stay was 17 days. Most patients were African American females. The average weight was 118.9 kilograms, and the average BMI was 43.8. All patients had at least one of the listed comorbidities, and more than half also had documented SEDs along with a pharmacologic VTE prophylaxis. Using conditional logistic regression, the odds ratio was 0.014, which was statistically significant. Because the odds ratio is less than 1, the odds of an association between the exposure of body weight dosing and the occurrence of VTEs are lower compared to standard dosing. When looking at all the patients in the study, about 71% of patients were on standard dosing, and the average time from admission to the first dose was 8 hours. The odds ratio for both major and minor bleeding are less than 1. However, both are not statistically significant. there was a 98% decrease in odds of major bleeding and 84% decrease of odds in minor bleeding with exposure to body weight dosing. 33% experienced a drop in hemoglobin of 1 or greater, with the main cause being due to dilution. Other reasons for the drop in hemoglobin included anemia and blood loss from unplanned surgeries during admission. Most patients received at most 2 units of packed red blood cells. However, one patient did receive 13 units. There was a total of 18 dose adjustments made, with 13 dose adjusted per protocol. Due to no dose adjustments per protocol in the case cohort, we were unable to conduct a chi-square test to assess the effect size. Listed here are the limitations. One of the biggest limitations to this study was the inability to eliminate all confounding factors, such as ICU admissions or transfers, and the effects of varying comorbidities. Because the occurrence of hospital-acquired VTE is so rare, we were unable to include 530 patients to meet power in our own health system to eliminate such confounding factors. As mentioned before, standard dosing of VTE prophylaxis is currently recommended for all hospitalized patients unless contraindicated. However, there is a lack of data and recommendations about the efficacy and safety of standard dosing in obese patients, especially prospective data. This case control study found that there were lower odds with exposure to body weight dosing with the occurrence of VTEs, major bleeds, and/or minor bleeds. The primary outcome was statistically significant, but the other results were not. One of the main contributors to the large effect size from the primary outcome was the lack of patients within the case cohort receiving body weight dosing. This is clinically significant because it points out the lack of usage of body weight dosing in hospitalized obese patients. To better assess the efficacy and safety of the use of body weight dosing, future studies with this design should be multi-center to be able to capture enough patients to meet power and to better evaluate the odds to the exposure of body weight dosing. In conclusion, the exposure to body weight dosing of unfractionated heparin for VTE prophylaxis in hospitalized obese patients were associated with less occurrences of VTEs. This was statistically and clinically significant. Retrospectively, there is a benefit in the use of body weight dosing in this patient population to prevent VTEs, but prospective studies are needed to better evaluate a true benefit. I would like to take a moment to acknowledge my amazing research team members. Please take a moment to answer this question. The purpose is to assess how the data from this study affects your current practice. There is no right or wrong answer. Thank you so much for your time. My email is available for any questions. I look forward to reviewing all feedback and questions from the audience.